Okay, so I'm going live. We're live in 5, 4, 3, 2, 1.
Good evening, everyone. We welcome you all to OrthoTV in association with UPOA and KOA to introduce today's program, and the speakers I hand over to Dr. Ajeet.
Good evening, friends. We are glad to present you 10th episode of Friday Musing of UP Orthopedic Associations. This is the second webinar of hand and wrist injuries. We are glad that we have brilliant faculties with us today, and we have the theme of today's webinar is not to miss the injuries, because we are going to discuss about the injuries which are very commonly missed in the hand and wrist. So with this, I would like to invite our Honorable President, Dr. Sanjay Dhawan, sir, for a welcome address. Over to you, sir.
Thank you, Ajeet. A very warm good evening to one and all present here. I welcome you all for joining us today on this webinar organized by KOA, the Kanpur Orthopaedic Association. This webinar on hand, and I congratulate the team KOA for constantly coming up with such an excellent series of hand and upper limb webinars. I'm also thankful to our President Atul, if he's there, as I can see here, for sparing time for our webinar. My sincere thanks goes to our faculty, Dr. Abhijeet, Dr. Pankaj, and Dr. Shailesh Gupta from Indore, and our panelist, Dr. Sanjay Rastogi, sir, from Kanpur, Dr. Maneeshi Bansal is not yet to join, and Dr. Gyaneshwar Tonk from Mallet, for sparing time to enlighten us with their wisdom. I'm sure that everyone is going to be benefited with their deliberations. Once again, I welcome you all. So without wasting much of your time, we'll just move on to academics. Thanks and best wishes. Over to Ajeet.
Thank you, sir. Thank you so much. Now I would like to request our Honorable President, Vice IUA Vice President, Dr. Atul Srivastava, sir. I think Atul sir is there.
He's not here.
Okay. So I would like to request our Secretary, Dr. Anup Agrawal, sir, for the introduction of panelists.
Thank you, Ajeet. So I welcome all our panelists and the faculty into this show today on the hand and webinar. And thank you everybody for joining us together. I'm sure all the delegates would be benefited by the intricacies of hand injuries and wrist trauma. Today we have very interesting topics, and I would say few of the topics are untouched also. So people will get to know a lot of things about. I have to share you one very important information. Being the chairman of CSRC IUA, we are celebrating 4th August as Bone and Joint Day and 1st to 7th August as Bone and Joint Week. So I'll request each and everyone to please celebrate the Bone and Joint Week with everything, whatever the theme is there. The theme is Save One and Save Self. So do follow the theme. We have made the DP profile for that. So I'll request everybody to make your profile photo of Instagram, Facebook, and WhatsApp as an IUA member, which we have already circulated. And please celebrate. Let the people know and the public know that what is Bone and Joint Day. So do a lot of awareness. Do online training on life, basic life-saving skills. So that is what I have to say. Once again, thank you, everyone. Thank you. Over to you, Ajeet.
Thank you, Anup sir. With this, we are going to start our first talk. I request to Dr. Abhijeet sir. Abhijeet sir is going to talk on perilunate injuries. I would like to tell you about. So please unmute. I don't know who is. So Abhijeet sir is my teacher, my mentor, and it's a proud for me that I got training of hand surgery under him. Dr. Abhijeet sir is fellowship trained. He has done fellowship from the Mayo Clinic and Climate Institute from the Louisville and the different prestigious institute of the world, and he's one of the he's the senior consultant and head of department in the Sancheti Hospital, Jahangir Hospital, and Sadri Hospital. He's one of those kind of persons who are the torchbearer of wrist arthroscopy in India. So we are proud to have you, sir. It's a privilege and honor for us today. You are with us, and I request you to talk on the perilunate injuries. So, sir, over to you, sir.
Thank you very much for that kind and very nice introduction, Ajeet. Although I'm not meritorious of such an elaborate introduction, it is indeed an honor for me to be a part of this August discussion with my dear friends and my senior colleagues, Dr. Shailesh Gupta and Dr. Pankaj, ahire, and of course, the office bearers and the dignitaries of the UPOA, the Kanpur Orthopaedic Association, and all those who are attending today, all my senior colleagues, friends, and my peers. And my task today is to talk about perilunate injuries or fracture dislocations. And as Ajeet rightly said, I think it is very important to understand from today's talk how not to miss these injuries. And that is something which is very important and very pertinent. And I really wish we had such talks and webinars and seminars when we were residents, and I wouldn't have been guilty of having missed them myself when I was training or even during the early stages of my practice. And trust me, even today, as a trained hand surgeon, I'm sure all my colleagues would also perhaps agree with me that every time we come across a complex looking X-ray, we are always so kind of conscious and jittery as to not miss an injury and be guilty of the same crime. So please indulge me today as I share with you a few insights and some musings as to how not to miss a perilunate injury. And let us start with a case example. Here is a 21-year-old right-hand dominant male who presented to us in the hospital, of course, to the trauma department with a history of slip and fall from a 10 feet height. And immediately, as would be understood, there was a major injury to the elbow. Unfortunately, I do not have the preoperative X-rays. And the elbow underwent an open reduction internal fixation. But 2 years down the line, he developed some kind of a wrist problem, and that is when he was referred to our department. And the X-rays were obtained, and the MRI was advised for the patient's complaints of something of a wrist fullness or a swelling in the wrist joint. And here are the findings of a clinical or a physical examination, and you will appreciate from this slide that the pinch and the grip strength was significantly reduced on the right side as compared to the left side. The wrist range of movement was also reduced, and the elbow was doing reasonably well. So let us now look at the initial X-rays, just kind of to reiterate. So these were the X-rays that he carried when he came to us. And although they were not the perfect X-rays, and it is usually, I'm sure all of you will concede that it is usually these kind of X-rays that will lead us to miss a perilunate injury. Now, the same X-rays I have zoomed in here, and to the discerning eyes of very many of you, I'm sure you would perhaps think that there is something going on which does not seem right. Yet, we are still not sure. We still don't know what is it that is exactly not right. And if you focus your attention to this corner, maybe, although this is not the perfect X-ray to look at, you might kind of imagine that there's something wrong with the lunate. And then when we get the proper X-rays, you will see, voila, eureka, the lunate is not in its place. However, let me be very, very forthcoming in saying that this may at the get-go not even be labeled as a lunate by the untrained eye. And this might also be labeled as a normal looking X-ray. So the same X-ray we demonstrated to our residents, the first year, the second year, and the third year orthopedic residents, and none of them could identify that there's something amiss even on the lateral view. The PA view also here might mislead us into believing that there is nothing wrong. So with that introduction, let us embark upon understanding how not to miss a perilunate injury or a perilunate fracture dislocation. There will be some jargon in terms of classification. There will be some jargon regarding the nomenclature, but please bear with me because this is an important topic which will help us understand the very basic tenets of diagnosing this injury. So here the MRI will show you the so-called spilled teacup sign, and now it's very clear that the capitate is not sitting into the cup of the lunate and the lunate is not sitting onto the distal radius. So now it's kind of very clear. So what are perilunate injuries and how do they occur? Perilunate injuries are the result of high energy trauma. And you can imagine that the lunate, which is labeled as a keystone of the wrist, is sandwiched between the distal carpal row and the distal radius. So it would take tremendous amount of energy to dislodge that lunate from its place. And it may be present with concomitant injuries, and then delayed diagnosis is as common as in 1/4 of the population of patients that present with perilunate injuries. The usual etiology is fall on an outstretched hand, something called as a fouche injury, wherein the wrist is in hyperextension as one tries to break the fall. The wrist is in ulnar deviation, and there is an intercarpal supination. When I say intercarpal supination, I'm talking about the intercalated segment, which is the proximal carpal row, which comprises of the scaphoid, lunate, and the triquetrum, and the distal carpal row. And there is an intercarpal supination, and this usually results in failure of the ligaments and fractures that may be associated, leading to these kind of injuries. So what we see is a severe disruption of carpal anatomy. These are rather uncommon but very challenging injuries, both in terms of diagnosis as well as treatment. They account for approximately 7% of all carpal trauma. So at a busy trauma center, you would end up seeing quite a bit of these injuries. And to add to all of these challenges, there is a multiple array of injury patterns. There is a myriad of injury patterns that bear different names and can make this topic very challenging. But let me try and make that as simple as possible today for you to understand how not to miss this injury. And then to add insult to the injury, we do not have a proven foolproof plan for management of these injuries. So let us now begin by understanding how to go about diagnosing this injury. So the physical examination will reveal that the wrist is swollen and painful. Again, a lot depends on the time frame in which the patient presents to us. On palpation, there is usually a dorsal prominence that may be attributed to the dislocated capitate. However, a caveat is that there is also a volar fracture dislocation or a volar dislocation pattern in which this finding may not be consistent. What we usually find is that the wrist and the finger movements are restricted because of the pain. So that is an additional finding. And in palmar lunate dislocation, which I just alluded to, there is a semi-flexed and a kind of a claw-like position of the hand, and there is very severe pain on finger extension. And this should not be confused with a compartment syndrome, obviously. Neurological examination is important because there might be median neuropathy, which may be attributed to direct pressure on the median nerve in the carpal tunnel because of the dislocated lunate. And we should look for the Tinel sign and any sensory neuropathy attributable to median nerve compression. Obviously, once you have done clinical examination, you would like to add a radiological examination to supplement your clinical examination, and these usually include a set of X-rays. Now, there is always a confusion regarding an AP view and a PA view. By default, we tend to say an AP view, but an AP view is an antero-posterior, so volar first, dorsal later, whereas the posterior-anterior view is when there is dorsal first and palmar later. So whenever we ask for an X-ray, it is advisable to ask for a PA view, a posterior anterior view, which is called as a neutral view with the elbow in 90 degrees flexion, the shoulder in 90 degrees of abduction, and the wrist in neutral. And focus only on the wrist and do not try to take an X-ray from the elbow to the wrist, because an inadequate set of radiographs is the single most important cause of missing the diagnosis. And again, there are several studies to say that 20% of these injuries are missed or misinterpreted on initial radiographs. So the usual sequence of X-rays that we ask for are a posterior-anterior view in the neutral position, a true lateral view, oblique views, and then traction views whenever there is a fracture that may be associated with these injuries. The PA view is helpful in understanding the carpal relationships with reference to the Gilliula's arc, and we will just come to that in a bit. We look at the scaphoid, and now we determine whether the scaphoid is flexed, which is called as a signet ring sign. We look for any overlapping of the carpal bones, and then we focus on the single most important cornerstone, that is the lunate. And on a posterior-anterior view, in the normal setting, the lunate should appear quadrangular or trapezoid and not triangular. So this is your very important caveat to not miss a dislocation. Now look at these two X-rays here for your reference. You can see the Gilliula's lines to the left of the screen being marked. There are 3 of them, pretty much like the Shenton's lines. So Louis Gilliula was a very famous radiologist who described these lines that bear his name and are eponymous with that name. And there are 3 lines, pretty much like the Shenton's lines, which, if broken, will lead you to suspect that there's something amiss, that we are kind of missing out on casual viewing of the X-rays. Now compare this X-ray with this X-ray. This is a simple scaphoid fracture for your reference, and you can see that the Gilliula's lines are broken, and then immediately there is a red flag that there's something going on in this X-ray. Now compare the Gilliula's lines that I showed on the previous slide with this X-ray, and let us look at it carefully. There is obviously loss of the Gilliula's arcs, both in the mid-carpal as well as the radiocarpal joint. You might think that the scaphoid is broken, and that perhaps is correct. What's more important is that the capitate also looks not normal. One cannot delineate the lunate, and then there is something going on here as well. So this is something more than what meets the eye. And before we kind of go into all these details, let us now understand the lateral view. In the true lateral view, the third metacarpal, the capitate, the lunate, and the distal radius should all be in one line. And there is one very important calculation that we make, and that is the scapholunate angle, which in the normal setting is anywhere between 40 to 60 degrees. Now, if you were to look at this X-ray, obviously the lunate is out, the capitate is dislocated dorsally, and then again, we would label this as a spilled teacup sign. And again, this will very simply help us understand that something is happening with the carpus. So historically, people have tried to understand the mechanisms of this injury dating back to the early 1900s, but it was essentially the Mayo group comprising of Drs. Lynchite, Dobbins, and Dr. Richard Berger, who really looked into the biomechanics, the anatomy of the carpal ligaments, and Dr. Mayfield did cadaver studies to describe the failure mechanism. So if you remember the classification of ankle injuries, we have the Loge-Hansen pattern of injury. For the elbow, we have something called as a Horry's circle. So similarly for the wrist, we have the Mayfield circle. So perilunate injuries are basically injuries that occur around the lunate, and therefore the lunate is called as a keystone of the carpus and acts as an intercalated segment, by which we mean that there are no direct tendinous insertion onto the lunate or the proximal carpal row, and the stability is imparted by only capsular and interosseous ligaments. And between these ligaments, there is a weak spot, which is called as a space of Poirier, which occurs on the volar side in the floor of the carpal tunnel, where we will see this soft kind of a weak spot between the radioscaphocapitate ligament and the long and the short radiolunate ligaments. And this is how it appears on a surgical perspective. Very quickly and very briefly, I won't belabor too much into the details and the jargon of the classification, but there are three types of classification that we should talk about. The dissociative one is when one of the ligaments binding the proximal carpal row bones is torn, so either a scapholunate or a lunotriquetral ligament injury. So this is called as carpal instability dissociative. The carpal bones are dissociating. We have a non-dissociative injury, which is called as when it is a radiocarpal, so the extrinsic ligaments are torn. So the carpal bones remain intact, but the relation between the distal radius and the carpal bones is lost, and you may have a radiocarpal or a midcarpal or an ulnar translation, as is seen in rheumatoid arthritis, for example. And then perilunate dislocations fall in the third category, which is called as a combined carpal instability. And this is the Mayo classification of carpal stability. So the carpal instability complex, again, has these subtypes. Again, we won't belabor too much on this. This is just for sake of completion. So please bear with me as I take you through this few slides. The Mayo classification, the Mayfield classification talks about the failure of these ligaments, and it usually occurs or almost always occurs from radial to ulnar in a circle. So the scapholunate will fail. There may be a fracture of the scaphoid. As the forces continue, there will be a fracture of the capitate and then of the hamate and then of the triquetrum. So this completes the entire circle. Or there may be just a pure ligamentous injury in which the lunate will dislocate, and these are referred to as greater or lesser arc injuries. Very simplistically, greater arc injuries are those when there are fractures associated with the dislocation, no fractures that are associated with the dislocation. So perilunate injuries basically falls into this concept of progressive stages of perilunar instability. I won't belabor too much on this, but this schematic diagram will perhaps help you understand the concept of greater and lesser arc injuries. So greater arc injuries involve a fracture. So the treatment for these injuries will depend upon the time frame in which the patient presents to you, the demands of the patient, the dominance of the hand, and of course, the presence of fractures that may be associated. Close reduction and cast was a thing of the past and is included only for historical sake, but there is something called as a Tavernier's method, which may be useful if the patient presents in the acute stage, and that may help you in close reduction and pinning, but more often than not, you would have to resort to an open reduction and internal fixation with ligament repair. So the treatment of these injuries can be very complex, and it is all to involve that colleague for the management of these complex injuries. Greater arc injuries, when there are fractures, will obviously require open reduction and internal fixation. In late presentation, we may attempt open reduction and internal fixation for injuries that are up to 6 weeks old, but we may have to resort to a salvage procedure for chronic injury. So here is an example where there is a trans-scaphoid perilunate injury, and you will appreciate that there is a fixation of the scaphoid with a headless compression screw. There is a wire that is stabilizing the scaphocapitate and the lunotriquetral articulation with a suture anchor here meant to repair the ligaments. One very important condition that we should not miss is something called as the Fenton syndrome or the scaphocapitate syndrome. In this case, what happens is because of hyperextension of the wrist joint during the fall, there is a fracture of the capitate head, which when reduced will flip 180 degrees so that the articular surface of the head of the capitate now faces the fracture side. So you remember this X-ray when we started the discussion. This is the PA view, this is the lateral view. You can see that there is the lunate which remains in place, the capitate is fractured and dislocated. And in this case, you may treat, this is not my case, I borrowed it from a friend of mine, and these were preliminary K wires and guide wires before the fixation was done. One very important caveat to understanding and not missing perilunate dislocations is to identify that rare patient where you have a palmar perilunate dislocation, in which case the scaphe or the capitate would now be volar rather than dorsal to the lunate. These are very rare injuries. Nevertheless, they do exist, and there are case reports describing this. Now, open approaches could either be dorsal or volar or combined, and each of them has their own advantages, which are enlisted in this case. More often than not, in chronic injuries, the volar approach is for decompression of the carpal tunnel with either reduction or excision of the lunate and repair of the volar ligaments. And then dorsally, you can perform your repairs or excision of the scaphoid and the triquetrum if you're performing a proximal row carpectomy. Guillaume Herzberg reported in 1993 on delayed presentation in the natural history. And you can see that there was a post-traumatic arthritis in all patients and a 1/3 incidence of carpal tunnel syndrome. Obviously, again, for the transcaphoid fracture dislocations, beware of scapholunate ligament disruptions and need to address them appropriately. Late presentations, again, usually fall in the purview of a salvage procedure. We never ever perform lunate excision alone, and understand that. Because if you excise the lunate alone, you're rendering the scaphoid and the triquetrum absolutely unattended to. The scaphoid wants to flex, the triquetrum wants to extend, and there is a complete disarray and a chaos. So whenever you are excising the lunate, you have to do something to stabilize or restore the kinematics and the kinetics, either by excising the scaphoid and the triquetrum, which is proximal row carpectomy, or by fusing the scaphoid to the capitate, then there prevent flexion of the scaphoid, and that is partial wrist fusion. So these are different. This is again a textbook picture wherein there is a partial there's a partial wrist fusion that was done, but this is a proximal row carpectomy and a total wrist fusion for advanced arthritis. So remember, last few slides, complications are common with perilunate injuries, and the best way to prevent complications is to avoid them. And how do you avoid them? Is by recognizing these patterns. You recognize these patterns when you bear in mind a high index of suspicion. Always understand that anything that comes in late is difficult to treat and will compromise the outcomes. So beware of these injuries and learn to identify them and treat them appropriately. Here is a list of complications that may be associated with perilunate injuries, and these have all been talked about. So let's not, again, belabor too much on this and spend time. So in conclusion, these are devastating injuries to the carpus. There is a spectrum of injuries that we need to understand. There is a variability of injury patterns, as we just talked about, with a variety of treatment options. And again, I reiterate that none of them are foolproof. So again, how not to miss the injuries is by entertaining a high index of suspicion for an accurate diagnosis with radiographs that are appropriate, and then trying to either train yourself or involve a trained hand surgeon in the management of these patients. So with that, I thank you for your attention and for the opportunity to share my thoughts with you, gentlemen. Thank you so much.
Thank you, Abhijeet.
Thank you.
Splendid talk. So I'd like to ask if anyone want to ask any questions, it's most welcome. Any panelist, Sanjay sir, anybody want to ask any question?
I would like to ask, it was an excellent presentation. is there any difference in the perilunate dislocation injuries in the pediatric population and adult population? How will diagnose and differentiate?
Thank you, sir. So perilunate injuries in the pediatric populations are extremely rare. And to be very honest, I don't remember having seen one because they end up having fascial injuries, and that kind of dissipates the force and the trauma and therefore prevent any such major injury. I don't have any personal experience with this. Maybe my senior colleagues, Dr. Gupta sir and Pankaj might have something to add to this. Do you, sir?
I have one case who was the adolescent kid around 14, 15-year-old who had a perilunate fracture dislocation, that to a very rare variety, volar perilunate dislocation. Adolescent and a volar perilunate dislocation. Usually the volar perilunate dislocation required a dual approach for the open reduction because there is a rent on the volar side of the joint capsule. If you don't repair, the injury will remain unstable and will tend to dislocate.
So I think it is towards when there is skeletal maturity that you see these injuries and not in the immature skeleton. Pankaj, how about you?
Yeah, apart from a scaphoid fracture, I have not seen any significant carpal injury in children till date. So I have zero experience as far as perilunate in children is concerned. So I assume it must be rare.
Right. So even I concede that I have seen a few scaphoid fractures, but I've never seen a transscaphoid perilunate or a perilunate fracture dislocation in the pediatric age group, sir.
Isn't it we can corroborate it that as the perilunate injuries is even missed in the adult population, very often the patients come very late with the perilunate injuries and the dislocation. So in the pediatric population, we much more often miss these injuries rather than we anticipate them.
But we don't see any late consequences so far. We have not seen a late consequences. So if there is an injury, there should be seen somewhere, maybe missed by some primary surgeon, but has to be seen by some other surgeon.
Maneeshi sir, can I come? So actually, Maneeshi sir, these kind of injuries, they are the high energy injuries. Generally happens because the fall from the height or the road traffic accident. Generally, high energy trauma is not very common in the pediatric age group. So it's most commonly happens when the patient has road traffic accident or the fall from the the greater height. So that's why that may be the reason it is not very commonly encountered in the pediatric age group.
Yes, absolutely, Ajeet. I was going to hint at that. The mechanism that causes perilunate is so much to do with an adult lifestyle and the requirements of life. Second, just like anywhere else in the body, the ligamentous injuries in pediatric age group are far less as compared to fractures that happen in the epiphyseal region or the metaphyseal region of a growing bone. That's where all the energy gets dissipated.
Yeah, thank you, sir.
So the elasticity is much better in the ligamentous.
Yes.
Yes.
Abhijeet sir, I have one question for you. So,
Sure.
As these injuries are oftenly missed, the patients come to the clinic very late. So what is your upper limit? I mean that when you consider that, okay, this month of the injury, patient can go for the open reduction. And after this much of time, patients need some kind of external fixator. Or indirectly, if I ask that, what is the role of external fixator in these kind of injuries?
Good question, Ajeet. And to be very forthcoming and honest with you, I have never ever used an external fixator for these injuries, although I know that this may be one of the ways by which you could facilitate the reduction. And I think Gupta sir and Pankaj, they do have some experience with this. Correct me if I'm wrong, but for me, the cutoff period is 6 weeks. If at 6 weeks, and especially if there's a greater arc injuries, by which I mean if there is a fracture that is associated, I would be more inclined towards performing a salvage procedures. My preferred salvage procedure, again, if the radial, the lunate fossa and the capitate head are intact, is a proximal rocarpectomy, or some kind of a limited carpal fusion. I do not attempt to either reduce or repair the ligaments beyond 6 to 8 weeks.
So if I understand right, it means that if any injury you are encountering after 6 weeks, then probably you will not go for the reconstruction procedure, you will go for this procedure.
And this is not just a gut feeling, or this is not my take. There is enough evidence in literature. There have been quite good papers that have been published out of Japan that show that 6 to 8 weeks is a reasonable time frame beyond which you should consider a salvage procedure vis-a-vis a repair or a reconstruction procedure. And there are studies that have compared the outcomes of trying to repair versus salvage, and the outcomes in the salvage group are systematically better.
Shailesh sir, if I'm not wrong, Prakash Kotwal sir has, I think, very good article.
For the distraction, first, initially in a late presentation cases, you distract the joint, keep it for 6 weeks, and then remove the fixator and try to relocate the dislocated structure anatomically. I tried this in one case, and incidentally he was an international player, and but I couldn't succeed. So always in cases of late presentation, take a consent for the salvage procedure whenever you are attempting an anatomical reduction. I have done successful reduction up to 3 months of post perilunate dislocation and fracture dislocation. Beyond 3 months, I had a great difficulty, and usually goes into the proximal row carpectomy.
Thank you, sir. Thank you, sir.
Abhijeet, what is the role of CT or MRI in this group of patients?
Very nice question, sir. So once you have a proper set of X-rays, and again, I reiterate at the cost of sounding repetitive, please get a neutral PA view, a true lateral view, and both oblique views. They are usually sufficient for diagnosing these injuries. However, there are some complex injury patterns, such as a scaphocapitate syndrome, or wherein the scaphoid might be too flexed after the fracture. In these cases, a CT scan is a very good adjunct to your radiological, investigations. In some cases, an MRI may be required, especially in the fresh injuries, such as a transscaphoid perilunate, wherein there might be some ligament injuries, and they are best picked up on an MRI. But again, in the acute setting, because of the hemarthrosis, because of the acute injury and the edema, these injuries may either be missed or they may be overdiagnosed. So we should take that with a pinch of salt and understand the injury patterns from clinical literature itself to have a high index of suspicion of what might be present, and use your investigations with a little bit of pinch of salt and judgment to try and understand what injury patterns might be anticipated when you're treating these injuries.
Dr. Abhijeet, could you elaborate on the oblique views, because true AP lateral, we do understand.
True. So when I'm talking of the oblique view, one is a scaphoid view, which is in about 35 to 45 degrees of pronation, and the other one is in the ulnar oblique view. So these are the two oblique views that we refer to. Again, like the PA view we already talked about, the true lateral view we already talked about, sir.
Thank you very much.
Thank you, sir.
Sanjay sir, Anup sir, any question?
Dr. Abhijeet, now if at all you are able to reduce it, close these injuries somehow. So we should go for a conservative method or treatment, or we need to operate on these cases, even if we get a close reduction?
Good question, sir. So if I were to just kind of play the devil's advocate and kind of go a step further, there are people who are using wrist arthroscopy also to help with the reduction techniques, and that kind of gives you the advantage of doing it under direct vision. Nevertheless, coming back to your question, what is important is when you are able to achieve the reduction, the question that we should ask is that reduction maintained when you carry the wrist through a range of movement? And if the stability, which again is very, very rare to have a case scenario with such a violent injury that the carpal anatomy and the relationships would be maintained with close reduction. In those cases, you might, even if you're not wanting to open up, pin these carpal bones. So the usual configuration is, which was elaborated well by Chaitanya Mudgal from Massachusetts General Hospital, is to have a quadrangular, pretty much trying to reinforce around the space of Poirier. So you have a scaphocapitate wire, you have a scapholunate wire, you have a lunotriquetral wire, and you have a wire from the triquetrum into the capitate. So of these, I personally would prefer to have a scaphocapitate, a scapholunate, and a lunotriquetral wire. And that itself kind of maintains the carpal alignment. And if you maintain them for about 6 weeks, the ligaments would, perhaps heal during that time and may have restoration of stability. But there are instances when there are complete disruptions, gross instability. Forget about the range of movement, that the reduction may not be stable in the neutral position also. And I think in those cases, we should consider an open repair of the ligaments.
Thank you, sir.
Thank you. Thank you.
Okay, if there's no question, then probably we'll move for the next talk. So I'd like to request Dr. Pankaj Ahire, sir. He will talk on the PIP joint injuries and the phalangeal fracture. So Dr. Pankaj Ahire is a senior consultant in Godrej Hospital, Mumbai. He is trained in hand surgery from Ganga Hospital, Coimbatore. And presently he is a secretary of the Indian Society of Surgery of Hand. He has very keen interest, and you can say that he is the person who always look in the wrist, and he is very fond of wrist injuries and the joint injuries, basically the interphalangeal joint injuries. So welcome, Pankaj sir, and over to you, sir.
Thank you. I hope you are able to hear me well and you can see my slide.
Yeah, very clear, sir.
Yeah, it's always a humbling experience to speak after Abhijeet. So thank you very much.
Thank you, Pankaj, for that. For that pun intended. Thank you so much.
It truly is. We go a long way for those who are listening to both of us together. So today, my brief today is to speak and restrict myself to injuries around the proximal phalanx, and that too only the proximal phalanx and the PIP joint. So I'm just going to restrict to that. So one of the commonest fractures in the proximal phalanx is the base extraarticular fractures of the proximal phalanx, almost always angulated, presents with quite dramatic deformities when it is in the peripheral digits, the index or the little finger. And I find one of the best methods to treat this is a plate osteosynthesis, as you would do for any other periarticular metaphyseal fracture. Allows very early mobilization. And this is the way the current available plates that we have allow us to fix this fracture. Compare this with a situation where you want to treat this conservatively and it leads to a deformity. And the deformity is when the fingers cross and they are malrotated, it's fairly disabling. And correcting these malunions is far more difficult than aggressively managing these injuries when they are fresh. So always think of the consequences of a malunion and having to correct a malunion in a tiny osteoporotic bone. And this particular patient had to undergo an open reduction to control the fixation. I think this was done long ago, and that time these plates were not available. These plates, I think, came into, 2010 onward, these type of plates are available in India. And then because of because I had used smooth wires, I also, gave kind of a static fixation to maintain the finger in safe position. So that's another lesson that we need to learn, is whenever we are treating phalangeal and metacarpal injuries, the ultimate goal has to be either immobilize the hand in a safe position, which is wrist dorsiflexion, MCP joint near 90 degrees. You don't have to make it 90, but near 90 degrees, and IP joints in extension. We have to be able to achieve that position. And if you don't want to immobilize naturally in that position, then naturally you have to be able to mobilize these injuries very, very quickly. You cannot have neither of the two and hope that the outcome will be good. It will not be. So almost similar looking fracture, it is always possible if you don't want to fix it by these elaborate methods. You can always treat it as a static traction. Again, important thing is if you want to immobilize with in a safe position and it will go on to do well. So is there still a role of plates in proximal phalanx fractures? Yes, I think there are some very definite indications. If you have multiple phalangeal fractures, doing a static traction may be very difficult. If you have a concomitant flexor or extensor tendon injury, which necessitates that we follow the mobilization protocol for the flexor or the extensor tendon, in that case, the underlying bone has to be fixed, stable, and therefore plating may become essential. If you have delayed presentation where you have to break the nascent malunion, I think plating is a good choice. When you have mature malunions or non-unions, I think plates have a distinct advantage over other methods of fixation. Is there still a role of K wires? Yes, intramedullary K wires. I'm not talking only about cross K wires which you drill through the bones. I'm talking about intramedullary K wires which are like any other bone inserted from an eccentric entry point. These are pre-bent wires. So if you have, these are the entry points for the wires. These are called the collateral recesses at the distal end of the P1. And from there, if you put pre-bent wires like this in a crossed fashion, they act like your Ender's nails or titanium elastic nails. These, of course, are stainless steel. These are the fractures where this type of wiring is very, very useful. So any fracture in the proximal 2/3 of the bone, you can fix by this method. So this is one of the examples of a shaft of P1 fixed by this method. When you have a TY configuration of the phalanx, of the base of the phalanx, I have taken example of thumb P1 because the sagittal, the dorsal and volar displacement is much more common in thumb P1 rather as compared to the finger P1. Finger P1 tends to have a more of a TY configuration in a coronal plane. Now, if you saw a TY fracture at any other joint in the body, you would immediately think of a stable articular fixation and early mobilization. That is exactly what we have to do in the phalanges as well. This was done again long ago, much before the plates and the screws, 1 millimeter screws came to India, fixed using, this is an open reduction, mind you. This is not a closed reduction. This is open reduction, multiple K wires. These are 0.6 and 0.8 K wires, and a fixator has been used only as a neutralizing device instead of a plaster. Though it has a distractor, it has not been used for distraction. And then you remove the distractor once the fracture is gummy and start mobilizing, and you get a joint which will now last a lifetime. Almost a similar looking fracture, and there has been an attempt to fix this using a fixator. Not my case, but I just thought it's important to point out that if you want to use a fixator, it is still important that you use it after the fractures has been finally reduced and fixed temporarily. Then you get the fixator to the aligned bone. Using the fixator to effect reduction is never a good idea, and this is what you may land up with. So open reduction of these fractures is almost mandatory. Let me take you through some other slightly uncommon ways of fixation of this fracture. This was a laceration of the extensor tendon with obviously a displaced fracture. And as I told you, this is one case where you need a stable fixation, because you don't want the extensor tendon repaired and then it remains in plaster for 3 weeks, 4 weeks. Plus, this is slightly beyond the ambit of K wires. It is in the distal 1/3. And I'm really not happy putting a plate in this region. I'm quite happy putting a plate in the base of the proximal phalanx. Here, with your lateral bands coming in the picture, and so the oblique retinacular fibers coming in the picture, I think this is a precarious region. So this was fixed using an intramedullary device. Now here I have used a scaphoid screw. This is a 2.4 mm, 2.5 mm scaphoid screw passed through the head of the phalanx, and it works very well, allows immediate mobilization. Another very bad fracture, open injury, flexor tendon was completely entrapped in this, and I was short of ideas how to fix it. All I did was, this is how open it was. I fixed the metacarpal stable using K wires, which went from 5th to 4th, and this part, the multiple pieces of P1 simply were tied together using Vicryl sutures. I just got the things together and allow it to become gummy. Eventually, it healed in this position, and this is the picture at the end of around 3 months. Patient needs now. I'm not going to correct this malunion. It's fairly well aligned. Patient does require scar release. There's a contracture release, and patient might require tenolysis because the extensor tendon was intact. So that is exactly what I'm going to do, and leave the bone alone. So it's possible to treat such bad looking fracture without any fancy fixation like a plate or an intramedullary screw. And this was another proximal phalanx fracture. This is on the day of presentation. You can still see the fresh scar. Now, this is an index finger fracture, and the patient is moving quite well. This is without any anesthesia. Patient is moving fairly well. It is rotationally well aligned. And now the dictum is, if the fracture is rotationally well aligned and patient has more than 50% of movement in the neighboring joints, you should think of treating this conservatively. And that's exactly what I tried to do. So this was the alignment on static photos. I just put the patient in a buddy tape and started mobilizing. And I started mobilizing. You would notice that as he extends, there is an angulation at the fracture that is happening. To negate that, I simply put a dorsal slab and then allowed the patient to mobilize within the slab. Again, if any immobilization is required, you have to be able to achieve safe position. That is the dictum in phalangeal and metacarpal fractures. So you have this unconventional methods of treatment, and you have plates and you have wires. And it's what is most important is the bottom line in all these things. One is, as I told you, is safe position, and you have to be able to move these joints very, very quickly. If at the end of a very fancy fixation, if you are not able to move and you are not able to allow the extensor and flexor tendons to glide, despite a good looking X-ray, you'll end up having a poor outcome. My next assignment is to talk about PIP joint injuries. This was a 52-year-old, very high-level government official, ambidextrous. She was fully immersed in work while this happened, and it was a trivial trauma. It was close reduced in the doctor's clinic where she went, and this is the injury X-ray that she came to me with, asking whether anything more needs to be done. Now, this is a tricky situation. You know that the joint is well reduced. You don't want to dislocate it and check whether it's unstable. So this is what you need to see when such a situation happens. You see that hyperextension that is happening. Now that hyperextension is happening because the volar structures, restraints have been torn, and that's why she had a dorsal dislocation. So if you want this to remain stable and these volar structures have to heal well, then you have to maintain this joint in a flexed position. Either you maintain them in a flexed position by some static splinting, or you can do something like a dynamic splinting. So this is what is called as a extension block splinting. Wait a minute. Yeah. So this is what is called as an extension block splinting. As you can see, there is a splint attached to P2 and there is a splint attached to P1, and these two are not attached to each other, but they act as a block, and it effects a 30-degree flexion. Now this 30-degree flexion will allow all the volar structures to heal, while this type of splinting will allow her to use the hand. She is allowed further flexion. So this is one of the methods of doing extension block splinting. Another patient like with a similar kind of injury, but as you can see, there is not much of hyperextension. And again, you need to talk to this patient. And if you are convinced that this patient will follow your advice of not passively hyperextending the joint and will continue doing flexion exercises, you can very well treat this without any splint as well. I did not make any attempt to fix this fracture because the joint was stable and he had more than 50% of active movement present without any anesthesia. And then he went on to heal very well. That's his healing. And this was at the time of discharge from treatment, this was his range of movement. So I was glad that I did not operate on him. So why do we, if they do so well otherwise, why do we still think of operating on this? Well, there are some clear reasons why we need to operate on the proximal, on the PIP joint fracture dislocations. Just take a good look at this picture. This is your proximal phalanx head. This is your P2 base, the middle phalanx base. This is your the red one is your collateral ligament proper. Yellow one is your accessory collateral ligament, where the accessory collateral ligament attaches on the volar side is your volar plate. And if you look at this ligament arrangement, the further slides will make a lot of sense. Now just extrapolate this to this. This is your classical dorsal fracture dislocation, PIP fracture dislocation. Just get the P1 out of equation at the moment. Just have a look at the base of P2. You see how much of that base of P2 is lost. I would say around 30 to 40%, more than half of it is present. So when you have only loss of 30 to 40% of the articular fragment, what happens is, it is much easier to reduce the joint, of course, and it can remain stable. Why would it remain stable? Because this collateral ligament is very much attached to the base of the middle phalanx, and it is not attached to this fragment. What is attached to this fragment is your accessory collateral and your volar plate, and therefore this becomes a stable fracture pattern. So if you have only 30 to 40% loss of the articular surface, it is possible to get a stable reduction. Another way of knowing whether this will remain stable or not is to check the amount of flexion that is required for the joint to remain reduced. If you require more than 30 degrees of flexion of the PIP joint to maintain reduction, it means this is unstable. So if it is a stable fracture pattern, it will remain stable anywhere between 0 to 30 degrees of flexion. If you require more than 30 degrees of flexion to keep the joint stable, the chances are your loss of articular surface is more than 40%, and it is an unstable fracture pattern and we will require surgical intervention. So when you have a stable fracture pattern only with 30 to 40% loss, you have reduced the fracture, it remains stable. But now you want this volar fragment to heal. Just like the first case that I told you, for the volar structures to heal, you just need to put it in 30 degrees of flexion. So the moment you put it in 30 degrees of flexion, the bone fragment is opposed, and you should allow it to heal in that position. There are methods, various methods by which you can maintain this 30-degree flexion. You can put an extension block K-wire. I do not prefer it now. There was a time when I used to do this regularly. I now prefer not to put a wire. You can simply put a splint and allow further flexion. So you put a dorsal splint and allow further flexion, or you can put a splint the way I showed you in the first example. Whichever way you do, you achieve something like this. And once you have a joint which is healed like this, you can now stretch out any amount of flexion deformity that you want. That is really not a big concern. Now take second example and contrast this with the case that we just saw. Just get the P1 out of equation and just see the amount of loss. If you draw a line in the middle of the shaft, you clearly know that this fragment is bigger than 50% and it's already malunited. And then when you have a joint like this, even if you try to reduce, it is not going to remain stable. Why? Because the collateral ligament is attached to the fractured fragment and not to the main shaft. Now, the only way this joint is going to remain stable is if we reduce this fragment. If we reduce this fragment in position and fix it, then only we will have a collateral ligament which is supporting the joint. So there is some method of fixation that is required. I have used a fixator here to maintain flexion. I no longer use it. And as I told you, once you maintain it in flexion and allow further flexion, this is how it will heal. And again, you have a flexion deformity. While treating these joints, if you have achieved a joint which is congruous, achieved a joint which is gliding into flexion, further flexion, and you have about 30 to 40 degrees of flexion deformity, I think you are on a winning path. Once you have this 30 to 40 degrees of flexion deformity, after about 6 weeks, anywhere between 6 to 12 weeks, you can start stretching it using what is called as a Kapner's splint. This is only after the fracture has healed. So there are injuries like this. This is fresh presentation. We'll go through a few clinical examples now that we have seen the background as to why we should fix them. Let's see how we could fix them. This was fixed using a volar approach and multiple screws. These are 1 millimeter screws. 4 screws have been put. 3 are optimal. 2 is a compromise, but sometimes it may be okay. And this is at around 3 weeks, this is the range of movement that you have. The near complete flexion and near complete extension. It's not 3 weeks. This I think is about 3 months. There's a slight flexion deformity. I'm quite happy to accept flexion deformity of about 10 degrees at the end of my treatment, as long as there is a joint which is gliding into complete flexion. This is another example, fracture dislocation. There is a articular depression, much like your tibial condyle. You can appreciate it in this enlarged view. What I did was opened it volarly and pushed the articular fragments into reduction and filled the gap with bone graft, cancellous bone graft. And 3 screws have been put. Important is to put nice bicortical screws so that you can have a compression across the metaphysis. Remember, for metaphysis, we always require an absolute stability. Because if you operate and if you are not able to mobilize, I think that's a recipe for disaster. So this is because it's fixed so stable, you can mobilize it fairly early. And as I told you, I'm really never worried about the flexion deformity. I'm worried about people not flexing. So this was another injury which was 1 month post injury, fairly shattered. I think this is beyond reconstruction. It is still possible. It is still possible to put these small pieces together, and you put a pull-out suture to the volar plate and put a dorsal button, and you see you get a fairly good alignment of the articular surface. And once you have a fairly good alignment of the articular surface, you are ready to move these early. And this is at the end of removal of the button at 6 weeks, and now there will be the flexion deformity will be stretched. As I told you, I'm really never worried about the flexion deformity. This was about 5.5 months old fracture dislocation, more than 50%. Intraoperatively, the phalangeal head cartilage was also not looking very good. So let's see how to deal with this type of injuries. So these are the ones where the lip is completely non-reconstructible and we require some method of salvaging. Like, we don't want to do arthrodesis in a PIP joint as far as possible. So what are the options that we have? One of the options that we have is say a case like this. One of the options we have is what is called as a volar plate arthroplasty. So what has been done is the bony piece has been removed and the volar plate has been advanced into the defect. This is the defect in which the volar plate has been advanced, and there is a button on top. And the second option is the hemiamate osteochondral graft. So you have two options to salvage, the volar plate arthroplasty and the hemiamate osteochondral graft. Let's come to our index case again. Just look at this picture and now look at the next line diagram. Again, this and this. So this is the dislocated joint. This is the fracture fragment, non-salvageable. And this is probably 3-4 months old. Now what you would want to do is, that is the volar plate, and you want to advance this volar plate into this defect. And these are the fragments which are completely non-salvageable. So what you do is you remove these non-salvageable bone fragments and throw them away. And then you advance the volar plate into this defect and anchor it using a pull-out button. You can fix the joint using a K-wire, though I rarely find it necessary. You can definitely put an extension block wire and allow further flexion. So this is volar plate arthroplasty. It is good if there is less than 50% bone loss, but however, there is always a chance of recurrent subluxation because of stretching of the tissues. So this is what was done. This was the X-ray that I showed you for volar plate arthroplasty. And this is the outcome of that volar plate arthroplasty. That the right side is the one which is operated. And the 5.5-month-old dislocation, this is what was done. I distracted the joint to effect reduction. And then he went for a hemihamate arthroplasty. So this is what is called as a shotgun approach. This is the head of the proximal phalanx. This is the dorsal lip of the middle phalanx base. And this is the volar lip which is fractured. The volar lip is completely removed. And now you create a nice defect. Then you salvage an osteochondral graft from hamate. This is the osteochondral graft from hamate. And then you put that graft here and fix it using 1, 2, and 3 screws. And this is what you get at the end of fixation. So that's the hemiamate graft, and this is what you get at the end of fixation. And that is the on table. This is what you get with a hemihamate arthroplasty. This is 3 weeks. On table is slightly before that, maybe. Yeah, this is on table. This is done wide awake, so you can check it on table right away. This is almost from a fixed deformity of 60 degrees of flexion to all near full range of motion you can restore. And this was around 3 months. That's the healed scar of volar approach. So to summarize, if you have a pure dislocation, remember there is still a volar plate injury and you have to make that volar plate heal predictably, and therefore extension block splinting becomes important. A stable fracture pattern, I have already explained to you how to identify stable fracture pattern. Close reduction may be sufficient. However, you still have to use the volar to extension blocking. You have an unstable fracture pattern. I told you how to identify an unstable fracture pattern. You need to fix and create a good volar buttress. And when you have a neglected fracture dislocations of the PIP joint, volar plate arthroplasty and hemihamate arthroplasty both can give you a joint which will move well and last the patient's lifetime. Thank you very much. Happy to take any questions.
Yeah, thank you, sir. It's a brilliant talk, sir. Yes, sir. Gyaneshwar, sir, please.
Dr. Pankaj, I have a question that
Yes.
in case of stable volar plate fractures, which are less than 30% or suppose 35%, and they are quite, after 2-3 months, they are healed, but they works as a flexion block. They blocks the flexion movement of the finger. Then how they should be tackled? The answer is hemihamate graft or something else.
Okay. So, there are two questions to this. There are two parts to this question. If the joint is reduced and there is a flexion block because of a malunion, which is a rare situation.
It is a stable type of fracture dislocation.
So it is a reduced fracture dislocation.
Yeah.
And if there is a flexion block,
yes,
then if there is a definite flexion block, even at the end of 3 months, I would remove that flexion block surgically and reattach the volar plate.
Okay.
If the flexion, many of these patients actually have a hinged flexion. The joint is not reduced, but they develop a pseudo joint at the fracture, and they develop around 30 to 60 degrees movement. These are the patients who will require open reduction of the joint and perhaps a volar plate arthroplasty or hemihamate, depending on the amount of bone that is lost. If it is more than 50%, definitely a hemihamate. If it is less than 50%, you can do a hemihamate or a volar plate arthroplasty.
I am also having one other queries. Many times we are having open fractures of proximal phalanx, which are coming to us 3-4 days or 5 days later. Should we at that particular point of time, we address the fracture only, or simultaneously if there is any extensor or flexor slip tendon injuries, should they also be addressed, or they should be addressed later on?
So unless there is a obvious infection, the tendon injury should not be postponed. In clean wounds or wounds which render themselves clean after debridement, primary fracture fixation and primary repair of the tendon should be undertaken.
Even 4-5 days or
100%.
Okay.
Any more questions?
Dr. Pankaj, how to put the oblique wires for the shaft proximal phalanx?
So as I explained, I do not try to drill these wires into the phalanx, because it's always difficult to start with the correct entry point and drill across the fracture. So the method is intramedullary pinning, much like how we put Ender's nails into femur or tibia. Same way, I create a 1.5 millimeter entry point at the collateral ligament, attachment, which is the collateral recess. And then I put 1 mm pre-bent K wires. I push them with hand. I do not try to drill these wires.
Thank you.
Pankaj,
yes, please.
You keep these wires flush with the bone, or you keep them outside?
I do keep them outside whenever I use them. However, I have found problem keeping them outside because they develop small granulomas around the wires. This is not my preferred method of fixation. My preferred method of fixation is either a screw or a plate. However, I would recommend that those people who want to use it, I would prefer that these wires be buried under the skin. I have regretted not burying them.
How long to keep these wires?
Until you see a radiological union, which is almost never before 6 weeks. 6 weeks is very optimistic for phalanges.
Even if you leave them outside, then you remove it after 6 months. 6 weeks.
Yes, that's the reason I feel it is much better to bury them, because they start developing small granulomas. But I would not take them out until I see a radiological union.
How early you mobilize finger? Immediate.
If I'm not able to immediately mobilize them, then the fixation has not done its job, and in that case I would immobilize them in a safe position irrespective of the fixation.
So what is the criteria that how you decide that this is very stable fixation, I can go start mobilization from the first day onwards, or when you decide that I should wait for the...
One is intraoperatively passive range of motion. Two, try to do these patients wide awake, so that once you have fixed, you are asked the patient to move early and see whether the fracture is able to stay reduced throughout the arc of movement. Three, if you have done it under a block or a general anesthesia, when they first visit you in the clinic, which has to be around 48 hours after surgery, and tolerating that post-operative pain, if the patient is able to move the neighboring joints through 50 degrees, 50% of the total range of motion available without any obvious deformity at the fracture site, then you know that this patient is ready for early mobilization.
Yes, sir. So what are the procedures do you recommend for the orthopedic surgeons for the unstable acute PIP joint injuries to do that? Because it's very difficult for the orthopedic surgeon to put the screws in the base of the volar lip of the middle phalanx, or some complex procedure of putting the plate. So what are your recommendations basically for the orthopedic surgeons for the unstable acute PIP joint dislocations?
Ajeet, I think as an orthopedic trained hand surgeon, all of us are much better off anatomically reducing the fractures and fixing them with appropriate size screws. Now we cannot put a 3.5 millimeter screw in the base of proximal phalanx. So we need to tone down our vision and force to put a 1 millimeter or 1.5 millimeter screw. If the surgeon really feels he cannot do a open reduction and internal fixation and put those small screws, then perhaps the next best option is a dynamic traction splint like a Suzuki frame. Now, I have never done a Suzuki frame in my career. So I can very confidently tell you that without Suzuki frame as well, you can treat all these acute fractures. Now, the fear of doing an open reduction in a tiny joint, or whether we should do an open reduction at 6 weeks. In my practice, the indications for roller plate arthroplasty and hemi-hamate arthroplasty have virtually boiled down to rarity. It is rarely that I do salvage procedures now. It means with time, it is becoming that much easier for me to start fixing the volar plate fractures, even as late as 3 months, and even with severe comminutions. So I feel anybody who wants to treat hand injuries will eventually be able to fix these fractures. If they cannot, then Suzuki frame is an option. Unfortunately, I have no experience with Suzuki frame.
Yes, sir. Thank you, sir. Thank you so much. It was a wonderful explanation. I have one case for you. So I have spared my questions for you to later on. I'll ask. So with this, we'll proceed for next talk. I'll request Dr. Shailesh Gupta, sir, to talk on the mallet injuries. Dr. Shailesh Gupta is a senior consultant in hand surgery from Indore. He has done fellowship from Kleiner Institute, Louisville, and he's trained wrist arthroscopy from the Germany. So over to you, Shailesh, sir. Shailesh, sir. Shailesh, sir, you're not audible.
Yeah, sorry, I was muted.
Yeah.
So Ajeet, thank you very much. Thank you for UP Orthopedic Association for inviting me to talk on mallet finger injuries. which every orthopedic surgeon come across so many times in a year, and at the end they are not happy patient. What to do? There is a residual deformity, there is a swan neck deformity. So how do you deal with the mallet finger injuries? So first you need to understand what is mallet finger. The mallet finger is a loss of continuity of the conjoint lateral band at the DIP joint, causing a flexion deformity. This is the flexion deformity, and there is a disruption of tendon somewhere here or avulsion of bone from here that result into the flexion deformity. However, you can do the passive extension of the finger at the DIP joint. Remember, there is no fixed deformity in the mallet finger injuries. So what is my approach? You require much more talking than doing. You need to explain to the patient that you will require a long period of follow-up. You will have to have a splint for 6 weeks to 8 weeks of time, then continue night splint for a few more months. It's not depend upon surgeon. It's the nature has created the way to deal with this scar. Ultimately, when you are treating the mallet finger, you are basically trying to give a good scar, and you are following the scar healing pathology, that the scar will have a maturity for 6 month period of time. So small detail matters. You need to tell them that how frequently they have to visit, and it's a time consuming, and the patient feel that you have not done much. If you treat non-operatively, they never feel that something big is being done, and the end result may not be perfect. Especially in a non-compliant patient, universally the results are poor in whatever way of treatment you adopt. So you have to be very careful in selecting the patient, explaining the detail. You have to give, in for my practice, at least I spend around 30 minutes for a mallet finger patient to treat them before I start any active treatment in them. So how do you approach them? The mallet finger deformity, let's have an algorithm. The mallet finger deformity in a middle-aged male or female after forced hyperflexion, in suppose it's a 2-week-old injury. The X-ray is normal, but there is a classical deformity of flexion at the DIP joint. The passive extension is present and there is no active extension. You treat non-operatively. How do you treat non-operatively? It's by splint. This is my way of treatment, splint, and also it's a universally accepted way of treatment. How long is splint? The splint is for the 6 continuous week. If you remove, if the patient feel at 3 weeks that his deformity is corrected, and many a times they don't follow the advice, and then they discard this splint and again come with the same deformity. So from the outset, you must explain that this will be your splint protocol, clearly written in the language patient understood, that you will have to have a 6 weeks of continuous splint, 2 weeks of intermittent off and on splint, then 3 to 4 months of night splint. Discontinuation of treatment in between resulting to treatment failure, and they must visit us very frequently, at least once a week, because the skin gets often macerated because of sweating. In Indian condition, with a patient not compliant, they make the splint wet. So you have to make the splint alternate dorsal and volar to allow the breathing of the skin from volar side and then from the dorsal side. So and during all the treatment, you continue to mobilize the PIP joint, because you don't want to allow any of the other joint to stiff. It's a disaster if you make a deformity corrected but all other joint is stiff. It is a disaster for the patient. Sometimes the patient is non-compliant, can't be off for the long period of time, poor skin condition for sprintage, and there are logistic issues. Suppose patient is living 500 kilometers from your place. There is no facility or logistic thing to be repeatedly visiting to your clinic or your center, no nearby available orthopedic surgeon or a hand surgeon to take care of them. In that case, you put an oblique K wire. A single oblique K wire is more than enough to stabilize the joint and bury the K wire under the skin and keep it immobilize the DIP joint for 6 weeks and teach to the patient that you can keep the splint or change the splint off and on yourself, maintaining the hygiene of the skin, cleaning the skin. And then again, don't forget to continue to mobilize the PIP joint of the same hand, same finger, as well as all the remaining joint of the hand, so that it doesn't get stiff. It's like it's a 2K wire because of that 2K wire has been placed, but usually 1K wire is sufficient. How do you treat them by splint? This is a Ilioform splint which I use. This is ready for putting on the dorsal aspect of the DIP joint. This is how you put it. Then you can see the flexion deformity. Put another micropore, make it deformity corrected like this. And then next week you alternate with the volar splint so that the dorsal skin will be allowed to breathe without any pressure when the volar splint is being taken care. So the next week you again convert into the dorsal splint and again volar. This is how you do every alternate week. Usually patient is not able to do it. If you are treating them non-operatively, you have to have a continuous supervision of the patient yourself. If not, put an oblique K wire into the DIP joint, allow them to take care of the hand themselves and put the splint themselves only. When you have acute bony mallet finger, when there is no joint subluxation, remember, even if it is a 50% of the articular surface involvement and the joint is stable in the splint position, you don't need a surgery. You simply need to put the splint, observe the joint by radiological evaluation every week so that you are not missing any impending subluxation or subluxation of the joint. And if it is not there, you continue with the splint treatment. And when there is a joint subluxation, like in a cricketer, there is already evidence of some past injury, the joint is being subluxated like this. You put a dorsal block, Ishiguro technique, K wire. This is one of the example of delta frame, not done by me. It was done by my friend. I have never used it, and they claim it that you can start the immediate mobilization. I don't have the personal experience of using the delta frame. When you have an open mallet finger injury, there is a clear-cut laceration, there is a sharp injury. The anatomical structure in the location of skin laceration is a conjoint extensor tendon. So this open mallet finger required a debridement of the wound. You have to operate, you have to debride, and you have to repair the extensor tendon and fix the DIP joint. This fixation of the DIP joint allow you the ease of skin care and ease of splint care. Again, when you are relying solely on the splint, then you have to have alternate dorsal and volar splint, preventing the pressure. It's not possible with an open wound. This is how the extensor tendon has been lacerated. It was repaired. Sometimes you get a situation where there is a fracture, and on top of that, there is an avulsion of the extensor tendon in a pediatric age group, around 12-13-year-old child. It's an unusual injury. You can now, once you were not able to evaluate the same thing on the pre-op X-ray, but once you reduce the fracture and then you realize there is a no tenodesis effect, the thumb is lying in a constant flexion, and then you opened it up and you find it out that there is a avulsion of the extensor tendon. And once you fix with the button, over the button, and you can see that that was a small bony fragment, tiny fragment lying with the extensor tendon. So what are the rehabilitation protocol? The rehabilitation protocol is 6 to 8 weeks of continuous splint and 6 weeks of continuous sprint, and then from 6 weeks onward to 8 weeks, every 2 hours, patient will take off the sprint, do the active flexion and extension of the DIP joint, and again apply the sprint. And then he should himself take care of the skin condition by keeping it dry, washing it thoroughly, and reapplying the splint. From 8 week onward, he will discard the daytime splint and continue night splint for 3 to 4 months. Everybody will ask, why for total 6 months? See, we are allowing the extensor tendon gap to be healed by scar. The scar tissue healing physiology has a maturity period of six months, and after 6 months the scar gets stabilized. So during that period of time, before the 6 months, if you allow them to stage too much, the scar get lengthened, and again you come with the deformity. So that's the reason why you should continue the splint for 6 month period of time. When you have an elderly patient with a mallet finger deformity, the elderly people are often having a DYP joint arthritis. There is poor and fragile skin. They are prone for stiffness of other joint of the hand. A slightest degree of pain and immobilization of any finger of hand creates lots and lots of stiffness of other joints of the hand, resulting into the dysfunctional hand. So this type of patient should be supervisedly neglected and allow them to develop, continue with the mallet finger deformity. Remember, all mallet finger deformity will have a second degree swan neck deformity. And you must know that all mallet finger deformity, whether it is treated or untreated, will end up in a good function. There is absolutely no problem with the function with whatever the mallet finger deformity. It's only the cosmetic deformity, and especially the mallet finger deformity followed by the second degree swan neck deformity, resulting in cosmetic disfiguration, which prompt them to come for the treatment. So when you have a chronic mallet finger deformity, you can still try splintage up to 6-month-old injury. And if it is effective, nothing doing. If it is not effective and there is an extensor leg up to 35 to 40 degree, do a Fowler tenotomy. Again, what you do is you selectively cut the central slip, not to disturb the lateral band, so that the whole extensor mechanism will migrate proximally, and there will be effectively the slack at the DIP joint will be reduced. So effectively you are converting from a swan neck deformity to a milder boutonniere deformity. So converting one deformity to another deformity. It's irony of this treatment. So patient come for correction of the mallet finger or swan neck, and they have some boutonniere deformity. When the extensor leg of more than 45 degree, oblique retinacular ligament reconstruction and as a static tenodesis is a procedure of choice, like this. And this is another example of a patient, young patient, who had this type of fracture, open injury, which was fixed well elsewhere, and he had a good healing of the fracture, but he came out with this deformity. However, there was no functional deficit. Despite repeated questioning, he said, I don't have any functional problem, but I don't like this as a cosmetic deformity. So recently read the article in a Journal of Hand Surgery for the surgical treatment for chronic tendon mallet injury. They recreated the anatomy of extensor mechanism by using the palmaris longus tendon graft, making into two slip, attaching at the base of the distal phalanx dorsally, passing under the transverse retinaculum. Again, it is creating exactly following the natural anatomy of lateral band, and suturing into the lateral band on each side of the middle of the proximal phalanx. So effectively, you are making the same anatomical recreation for the chronic mallet finger deformity. So this is how It was done in this patient. There are two slips of the palmaris longus graft. One is going here, another going on the other side. And look at after the adjusting the tension, there is significant correction of the deformity. Patient is able to actively flex it. Look at the extension. He is doing flexion and extension on table. Again, it's a wide awake surgery, so you can test the flexion and extension. And then you stabilize the DIP joint extensor in a full extension by K wire. Allow them to start the PIP joint motion immediately. And he started with this, and he has a long-term follow-up of around a year like this. Almost full correction of the swan neck, still some residual 20 to 25 degree of the flexion deformity, but he is much happier. The reason for surgery was a cosmetic correction, and he feel I am cosmetically much better. Thank you very much for the patience listening.
Thank you, sir. Thank you so much. It was a wonderful outcome, sir. Dhawan sir, if you have permission, can I go for the case presentation? Because Abhijeet sir has emergency meeting. So, Dhawan sir. Sanjay Dhawan sir. Oh, I think Dhawan sir is not there. Anup sir. Abhijeet sir, are you there? Okay.
I will in the interest of time, you can present the case.
Okay.
Or you can ask permission from the Nadeem. Dr.
Yeah, Nadeem sir. Okay, let me see. There are so many people, but I think they have not. Dhawan sir, unmute yourself. Dhawan, sir, please unmute yourself. Yeah, Dhawan sir, I need your permission to start a case presentation.
You can have one case at least. We have already finished the time, but you can go ahead with the case presentation.
Neeraj sir, can I share my screen, please? Is my screen visible?
Not yet. Now it is visible.
Okay. Abhijeet sir, are you still here? Okay. So we have Pankaj sir and Shailesh Gupta sir. So this case is basically related with Abhijeet sir's talk. So there is a 35-year-old gentleman. He is basically farmer. He's right-hand dominant. He has a road traffic accident, basically the forearm outstretched hand injury. So on clinical exam, this injury was 1 month old injury. He has restricted movement, basically the flexion and extension. There was an obvious deformity at the wrist level, and there's a numbness of the index and middle fingers. So unfortunately, I missed the X-ray somewhere. So this is the CT scan finding of the patient. So Pankaj sir, would you like to comment something on this? Or Shailesh sir?
She has also come in.
Yeah, I'm around, but Pankaj, you could begin. No problem, please.
So this obviously is a perilunate injury. So you can see that the lunate is very much articulating with the radius. So the dislocation is at the mid-carpal level. In such injuries, it's always useful to look at the scaphoid, whether it is fractured or not. In the current images, I'm not able to see it very clearly. But yeah, in one of the images, I can see that it's very intact. So in that case, we definitely know that there's a complete disruption of the scapholunate ligament, without which this injury cannot happen. How many weeks you said, Ajeet, this was?
This is 1 month old injury, sir. It was neglected. It was missed.
Yeah. So even at 1 month, it will be always possible to reduce this. May require a open reduction. I would distract this preoperatively for over a period of 6 to 7 days. Allow the soft tissues to stretch and then operate. If not, I would even consider a single stage distraction and open reduction, acute distraction. I would do a dorsal approach, ensure anatomical reduction, put the lunate in a normal alignment, and start building structures around the lunate, namely the scapholunate ligament and the lunato-triquetral ligament. Ensure correct alignment of the capital lunate joint. The lunate has to be in its anatomical position before you start building around it. That would be my plan.
So, sir, would you like to go only dorsal approach or volar too, as patient has numbness in the index and middle finger?
That's a tricky one. If I might consider both, but I think I would just go dorsal and reduce. If it reduces, I know the carpal tunnel will get decompressed.
Correct, sir. So would you like to reconstruct the scapholunate ligament, or would you like to go for the repair, kind of repair?
At 4 weeks, I would repair it.
So what should be the mode of repair, sir? Is it direct repair or using kind of some anchor sutures or something?
Yeah, I would use an anchor suture.
Okay.
So typically you will always find a stump which is attached to the scaphoid, and then you may put an anchor in the lunate using a 4/0 fiber wire anchor, and then in fact you can now and then you can use the same fiber wire to do an internal splinting as well by putting an anchor into the scaphoid. Basically an anchor repair using fiber wire.
Correct, sir. Fair enough. So Abhijeet sir and Shailesh sir, the same plan, or would you like to differ with the Pankaj sir's plan?
Same dorsal approach. No use of distraction. I have not done it up to 2 months period of time. I don't feel it is required. Yes, I would do for the carpal tunnel decompression immediately, because it will be difficult for me to answer if it is not been, why it has not been done. There is no harm in doing it. There is enough of evidence of symptoms of carpal tunnel syndrome, and I use it. Yeah, I always, as Pankaj said, I always build up the things around lunate. But what other people don't do and I do is I always put a wire from the capitate to lunate to radius, and that acts as a very much stabilizing K wire. On that I built everything.
So volar approach to just to release the carpal tunnel?
Yes, absolutely.
Or for the repair of the volar capsule too?
It's for the pure dorsal dislocation, it is not required.
Okay. So
but when you are doing a carpal tunnel, there is no harm in looking at the base of the carpal tunnel at the volar wrist joint. If there is a rent, put some 2 suture, 3 suture, that will be enough.
Okay.
But if there was no carpal tunnel, I would not do the volar approach.
Okay.
Can I say something, Ajeet, please?
Yes, please, Abhijeet sir.
Yeah, thank you very much. This is an interesting case. And over the years, when I was a young enthusiast, and we used to come across these injuries, and when we would be more inclined towards trying to do our best in restoring the anatomy, to having a few gray hair now. My enthusiasm for chronic injuries such as these and to attempt to reduce and stabilize has been dampened a little bit. When you look at these injuries and you approach them from the volar aspect, you would find that there is a lot of fibrosis and the lunate is practically tethered down and has almost herniated from the space of Poirier. So although like Pankaj did say that it might be possible to reduce this injury only from the dorsal approach, it may pose very serious challenges because dorsally there's a lot of scar tissue, pretty much like the pulvinar in a DDH. And you have to release all of those soft tissues to be able to have, and the risk of trying to reduce such a tight and a chronic dislocation is iatrogenic chondral injury, especially to the head of the capitate. The second thing is that scapholunate ligaments with such kind of a violent injury, and you can see on your 3D reconstructions, look at that wide gap. These pose very serious challenges, not only for repairs, but even reconstructions for that matter. And it's not easy to kind of restore the anatomy of the scapholunate and to stabilize the wrist. So with these thoughts in mind, I would counsel the patient for a salvage procedure. If the reduction might be too difficult or may not be a tangible goal, and proximal row carpectomies, and Pankaj is perhaps a torchbearer for proximal row carpectomies, and he has shown such excellent outcomes. They serve and they fit this kind of a scenario very well, and I wouldn't hesitate to perform a salvage procedures for such cases. Just my thoughts. Thank you.
Okay, sir. So what I did, I would like to show you that. Just a minute. So I went from dorsal approach. This is ligament sparing approach of Burgess. When this is the the space where the lunate has dislocated on the volar side. This is the X-ray after reduction. I could have reduced it easily, but you can see there's wide gap in the scapholunate area and the lunotraquetral area. And it was quite unstable, so that I choose to put one wire from the radius to the lunate to stabilize lunate in the lunate fossa. And you can see the video of that how. So this is a scaphoid, this is the lunate. And see the gap in between the scaphoid and lunate. There was wide gap and it was completely dislocated. So what I did that I first stabilized the lunate with the radius, and the wire I passed from the lunate and radius, I stabilized it first, and then I stabilized scaphoid with the lunate and the lunate with triquetrum. And there was actually there was anchor was not there, so I make a hole in the lunate and repair the scapholunate ligament with the ithibond. And this is kind of movement I got after the repair. And this is after the repair of the capsule, and then I repaired the extensor retinaculum. And this is the final outcome after the repair of the ligaments and the stabilization of the carpal bones. So I don't have, actually, this is just few days back, around 15, 20 days back, I have operated this patient. I don't have follow-up. So it's too early to say that it was wonderful procedure unless the patient has optimum outcome or optimum movement at the wrist level. So any comment or any advice?
Splendid. But like you rightly said, the test of the pie is in tasting it. So it'll be very interesting if you could share the outcomes at some time. Thank you.
Yes, definitely, sir.
Next case. Ajit, you have gone for the carpal tunnel release simultaneously?
No, I have not. I have not released, sir. I have not.
And his symptoms has gone.
Yes, his symptom has gone, sir. I have not released the carpal tunnel, sir.
So you have to counsel that if the symptom doesn't go, then you will go for the carpal tunnel is in second stage.
Yes, 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 sir. So there is another patient who is 22-year-old gentleman. He's basically the student. He's an aspirant of, that the he has qualified for the sub-inspector and he has cleared the exam. The problem has happened that he has road traffic accident. He has fell from the bike and there was a closed injury of the wrist and the open injury of the index finger of the right index finger. If you'll see that this is the X-ray. He came to me with this X-ray. There's an injury at the PIP joint, and you can say that the middle phalanx base. Pankaj sir? Pankaj sir? Pankaj sir is still there or not?
Yeah, yes. Ajeet, can you come back with your question, please? I think I lost the voice for some time.
Okay. So he's a young gentleman. He has.
So I got that. What is your question now?
So this is the X-ray of the middle phalanx. So
yes.
Obviously this is not very good X-ray. You would like to see the other views, like this is the lateral view.
Yeah. So first and foremost, if I have to plan the treatment of the middle phalanx fracture, I would take a focused X-ray of the finger alone. Okay, I would not digitally cut and enlarge it. I will just take a focused X-ray, assuming this is an extra-articular fracture. Okay, I would consider putting a K-wire from the collateral recess of P2, so from distal to proximal. I expect that I will at the most get only one wire from distal to proximal. I will attempt to put a second wire from proximal to distal from one of the corners or the base of the P2 across, and that's it. This should be typically a close reduction. That's all I have to say about this injury.
So just I would like to tell you that this is the open injury.
Yeah, can you show me the picture of the open injury, please?
Actually, I don't have pictures. So this is what I found after opening. There was actually, it was open injury. So
open injury, was there a tendon laceration?
Yes, there's a zone 3 tendon injuries there also. Yeah. There's a laceration.
Yeah, so then the tendon injury guides the treatment. Whatever is required for early mobilization of the tendon. So do you mean there was the lateral slips were divided?
No, sir.
And the central slip was still attached to the base, was it?
The central slip was divided, sir. I mean that it was injury has happened over the zone 2 and 3 both, because it was a big kind of laceration.
Okay.
Kind of crush injury.
Okay.
And if you see, this is the head of the P1. So there is a chondral injury. So there's cartilage injuries there. There's intra-articular fracture of the P2 base.
Okay.
I think it will be more clear in this next image. Yeah. If you see, this is the head-on position. I mean that this is the head of the P1. And this is the base of the P2.
Yes. Okay. So there seems to be an extensive loss of the cartilage of the P1 head.
Yes.
Yeah. In that case, I would not hesitate offering this patient a primary arthrodesis.
Okay.
I would allow it to shorten and do a primary arthrodesis.
As he's an aspirant and he has came to me for the movement of the PIP joint, and he has a lot of hope. He would like he has qualified the exam and his physical was waiting. So
I understand you did not do an arthrodesis, but I would offer an arthrodesis.
Okay, so what I did that whatever the cartilage was there, I used very fine sutures and repair the cartilage over the bone, and then I fix it. So I put the fixator, just fixator to distract the joint, and luckily I could have catch the volar fragment from the one K wire.
Okay.
So this way it reduced the fracture. And this is the tendon which I repaired because it was, the kind of shredding of the extensor tendon. So it was not very good quality of extensor tendon. So somehow I managed to repair the tendon. And this is the outcome.
This is an excellent outcome. And
Fantastic.
yeah.
The patient has, I think, complete extension, complete flexion.
This is an excellent outcome, and I'm
And this is the
not
X-ray.
have been able to give this.
Sorry, sir. If you'll see, this is the joint. I think there's some cartilage damage was there, so you can see that kind of some wired over the dorsal head of the P1.
So,
how many days it will last, but currently he has this movement, and I hope that he will get the job.
Excellent.
This is the video I have.
This is absolutely excellent. There's no doubt about that.
So only this was the case. Okay. Any other questions? Any other? If anyone has any doubt, any questions, can ask to the speakers. Panelists, please. Nadeem sir, any question do you have? Sanjay Rastogi sir?
No.
Ashish sir? Ashish sir?
हाँ भैया, मैं सुन रहा था, लगातार बहुत कठिन कठिन बातें हैं, सवाल नहीं हमारे कोई, बढ़िया है.
Sir is our UPOA president elect. He will be our next president of UP Orthopedic Association.
Okay.
ठीक बात है. Good evening to all.
Good evening.
So if we don't have any questions, Nadeem sir, I would have request to you that please give vote of thanks to all the speakers. They have spared their time and they have enlightened us.
But I think that was an excellent session we had. Start off with, I would like to thank Dr. Abhijeet. He is a teacher of teaching. He made such a difficult topic sound so simple. I think it was an excellent lecture.
So your voice is very slow, sir. Can you increase your volume?
Dr. Pankaj, I think. Sorry. Can you hear me?
Yeah. Yes, sir.
Yes.
Dr. Pankaj, that was an excellent talk. I mean, the thing that I liked was that you emphasized more on very simple techniques of treating these fractures, which I think a lot of us in UP can do. It's not you did not show the very complicated methods of treating such fractures, which is very good. I was thinking that, I mean, from Bombay, you would show us some of the latest techniques, and that would be something which we would not be able to do in UP. But I was very happy that you showed us techniques which most of us can do in our place. And Dr. Shailesh, it is a very common injury, and biggest surprise to me was that you want us to sprint it for 6 weeks, 6 months. I mean, I thought was 6 weeks was the end. If you could give I don't know how you are able to manage to retain these patients on the sprint for 6 months. By 6 weeks, patients are fed up and they want to get rid of that sprint. But it was a big eye opener to me. And I would like to thank all the panelists, Dr. Sanjay Rastogi, Dr. Gyaneshwar Tonk, and Dr. Maneeshi. Dr. Maneeshi has left, he had to go somewhere. And I would like to thank our President and Secretary of the UP Orthopaedic Association as well for allowing Kanpur Orthopaedic Association. And a lot of thanks to Dr. Ajeet Tiwari for organizing such beautiful lectures. And I would also like to thank all the people who have attended, and I'm sure they've gained a lot from these lectures. And I would like to thank you all once again. Thank you. Good night.
Thank you, sir. Thank you. Thank you all. Thank you.